You're watching a special edition of the Wellness Hour. I'm Randy Alvarez. We're here in Indio. We brought the Wellness Hour cameras live. We are going to go into the Breast Health Center with Dr. Marla Lander. If you want to know more about what you can do to reduce your risk of breast cancer, my advice, stick around for the latest edition of the Wellness Hour.
The Wellness Hour, an in-depth discussion with today's top physicians and medical leaders. And now, your host, Randy Alvarez.
We're inside the Breast Health Center. We're waiting on Dr. Marla Lander. In fact, there she is right now. Dr. Lander, how are you?
Hi, Randy. Good
Great.
to see you. Thanks
Good-looking
for coming.
place.
Randy, let me show you the conference room to start out our tour.
So what goes on in here?
Our nutritionist and exercise physiologist meets with patients, and she discusses with them nutritional plans, lifestyle changes, dietary strategies, exercise plans. We have workshops, osteoporosis workshops, breast cancer reduction risk workshops, and sometimes even tumor board.
Okay.
Let me take you around to the rest of the facility now.
Great.
One of the unique properties, I think, of the Breast Center is the extensive art collection we have here.
Yeah, it's filled with art.
From all different time periods and all different styles. And
Now, why the art in a breast center?
one of the reasons
I mean, for sale. I mean, you sell it.
we do sell it, the reason why we have the art in the first place is because a woman comes here and usually she's tense. She doesn't know what we're going to find. And the art really helps them to relax, project themselves somewhere else. Just an area of interest occupies their mind instead
Okay.
of sitting there and worrying. And also it's for sale because, believe it or not, it augments the income of the breast center. Mammography is one of the lowest paid fields in medicine right now.
Okay,
Let me show
great.
you this wall.
Now, what is this we're looking at?
When I did my training in Sweden, we had one of only a couple of three-dimensional microscopes. So this is actually different pieces of breast tissue, and these are just stills, so we can't cruise through them three-dimensionally. But when you're there, you can actually go through these like it was a roller coaster.
Is that right?
Some of the things on this wall are normal anatomy. This is a duct that's not filled with milk, and you can see that it's pleated because it's not extended with fluid. If you look right here, this one is extended with fluid. This could be a lactating mom, just to see a difference. And then if you look at the one on the far right, that is a duct that's filled not with fluid but with cancer cells. Let me show you my own personal collection that I call the
This is
Wailing
it.
Wall.
All of
This
your
is it.
certificates, okay.
This is,
A lot of years in school.
yeah, 15 years in higher education to obtain these pieces of paper, Randy.
And your office kids you about it.
They do. They do. And it's off to the side so the patients don't have to see all the different pieces of paper, but it's there to prove that I am who I am if they want to
That you
see
are
it.
a real doctor.
I really am.
Okay, good. Now we're going to take a look at the where somebody goes in to get a mammogram. Is that right?
This is a modern mammography unit, Randy.
Okay.
And it's where we bring the women to do their mammograms, screening and
So
diagnostic.
the balloon, why is the balloon there?
Balloon's there to illustrate that compression doesn't have to hurt, and people have this concept that it can be dangerous and actually cause damage to their breast.
So this right here, this is where the woman places her breast. This is what they complain about.
Correct.
Okay.
The technologist would come around.
So she's by there, behind there.
When she has the woman positioned, and we're pretending that the balloon is the woman's breast, she's positioned the woman's hands and face are placed accordingly. Then she will step behind the lead shield, because even though mammography is very low dose radiation, she doesn't step behind a lead shield. She's doing this every 15 minutes all day long, so it does add up.
So this goes up and down.
This goes
to the
up
height
and
of
down at angles 180 degrees, 360 degrees, I think.
Sure.
This is actually Karina's area of expertise, and then my expertise falls afterwards when I get to read the films.
Now why compression? It seems like after all these years there would be a better way than this procedure.
That is such an important question, Randy. I'm really glad you asked that, because that's a concern women have. And the reason why we do compression is manyfold. One of them is that it reduces radiation exposure to the breast.
Okay.
If you think of a dog pile,
Right.
and the X-ray beam has to go through a thick layer of dogs, it's going to take a lot more radiation than if you smooth out the dogs and they're only too thick.
Interesting. Okay.
So it's much less radiation. There's less blurring because the woman can't move. She's held in compression. If she moves, then we have to retake the mammogram, which is additional radiation. And it decreases blurring because she's not moving, as well as it decreases scatter, which is a very technical term. But the X-ray beam comes in and then the photons jump all around in here. So the less room they have to jump around, they'll be more true to the straight vertical, and we'll get a cleaner picture.
Now you say there's technique to this. That means that some people are better at giving this than others, as far as pain. Is that right?
Right,
you
and
like
that
to
has
think
to
that
do with the positioning. And because this unit is so mobile and can accommodate any body size or shape, the technologist who really knows what they're doing and is willing to take the time to take a woman through this painlessly will assess the woman's body, especially the pectoralis muscle, which goes from your sternum up to your humeral head, and that's at a different angle. So when she's doing one particular view called an MLO view, she's going to adjust her machine so that it parallels the angle of that muscle, and then when she puts compression down, there's no pain associated with it.
Do you have women that come in here and say, I've had these exams done elsewhere, and they were nothing like this?
Yes.
Is that common, really?
It actually is common, and it's unfortunate. The technologists are so priceless in this field, and I really owe a lot to my technologists. They're excellent. They make the woman feel comfortable, and you know, if you're feeling comfortable, your muscles aren't tense, and the whole experience is going to be a lot more gentle on you, more relaxed.
Can I feel the pressure on this machine?
Yeah, absolutely. Karina, you want to put
Because I hear the complaint,
out?
and I anticipate in this interview, I've talked to a lot of the women, and they say, well, you know, I'm worried, I've heard it's painful, things like that.
Go ahead and just put your fist under
Fist
here.
right here, okay.
Karina's just going to gently bring it down.
Can you mimic this is what I would feel. This is the pressure.
What you would feel.
This is the pressure. Okay. It's not so bad. No.
He's at 16 pounds of pressure there.
Not at all. Sure.
Exactly.
So that's what they feel.
Yeah, and I always tease them. It's not something they're going to do for fun, but it shouldn't be painful.
How long does it take to do? I mean, was that a simulation of actual time?
Yes, except it takes some time to position in between.
Okay.
If you were taking the exposure, how many seconds is it usually, Karina? So it's 3 to 4 seconds, I would say, per exposure. And so most of your time is actually in positioning, not in the time that the radiation is produced.
So you want women to come annually for this?
Absolutely.
Is it fair to say?
After the age of 40.
After the age of 40. If they come to see you once a year, very slim chance that they're going to die of breast cancer. Is that fair to say?
Yes.
And I guess the challenge and the part I don't understand is, and we've talked, I guess the numbers are, you know, about 40% of women overall don't come in for their annual exams. Is that right?
That's in the state of California. 39% of women that are age eligible for mammograms aren't doing annual examinations. In the rest of the nation, it's actually worse. I've heard some papers quote as much as 60% of women aren't getting their mammograms.
Now the process, by the way, they come in, they, of course, medical history, things like that. They could be in and out of here in how long?
For screening mammograms, usually 15 minutes.
15 minutes, and to save their lives. Interesting.
The diagnostics take longer because I intervene, and I'm the one that slows down the process.
Now you also read all the images?
I do. I read the
and
images,
that's not
and I do
the
the
way it's done.
ultrasounds.
And that's not the way it's always done. Is that right?
Correct. Some centers will have multiple radiologists reading the images, some fellowship trained in mammography, some not. The advice that I would give a woman is that they should call the breast center and make sure that the physician reading the mammograms has a lot of experience and, if possible, even fellowship training in breast imaging.
If you find something, do you personally go over those findings with the patient?
I do. I have a very hands-on approach.
Okay.
We have all these modalities available at this center, but it's still a small center, and we do a small volume so I can spend time with patients.
Sure. What about radiation? I always hear about radiation. Something to worry about?
It's actually not something to worry about. In technical terms, a 4-view mammogram, which is your basic screening mammogram, is 200 millirems. And to give you a comparison, because 200 millirems doesn't mean much to people, that would be equivalent to only the exposure your breast would get in an airplane flight for less than 20
So
minutes.
it sounds silly to you when somebody says, I'd like to get one, but the danger of radiation is too high.
It does. Or it's the same thing as just being alive on this earth for 200 days.
Okay.
It's very minimal. And I was just reading a paper, Randy, that they said the risk of actually getting cancer from the radiation exposure from a mammogram is only theoretical. And if you looked at a woman who starts getting mammograms at the age of 40 every year, there is, the ratio they said was 121 years of life that's saved over 1 year that might be lost from radiation. This is our DEXA room, and DEXA measures bone mineral density, which is a very important component of osteoporosis, which osteoporosis is a combination actually of microarchitectural deterioration in the bone and bone mineral density. But by measuring bone mineral density, we can accurately predict somebody's fracture risk.
So not only your current patients come in here, anyone can come here for a bone density, is that right?
With a doctor's prescription, anybody can come in for a bone mineral density test.
Now this ultrasound machine, you say 10 in the United States, and you have one.
Correct. We have one of 10 in the United States.
What's so special about it?
What's special about it is that it's automated, unlike
Okay.
your traditional handheld ultrasound.
Yeah, what does that mean?
And also, it's digital,
Okay.
although some handheld ultrasounds can be digital. What it means by automated is that a patient's lying here, and we've simulated this with a balloon, pretending that the balloon, again, is her breast. And Cheryl's going to show you right now the transducers taking information from the balloon.
So in what case does somebody have this ultrasound done over a mammogram? Does this go together? Tell me
It
about
does go together, Randy. And what we're trying to do with this machine is do screening ultrasounds. And up to this point, basically, Medicare and insurances only allow diagnostic ultrasounds, or if a woman has a problem, then we can do ultrasound. But what about the women who have extremely optically dense breasts? You might miss something by mammography, and it'd be great to have a system like this.
A dense breast, is that a leaner woman?
Not necessarily.
Younger patient?
Not necessarily. It just has to do with the fibrous background of the breast, and the what we call the parenchyma, the milk glandular tissue, can just be extremely dense.
So with not all ultrasounds being the same, this is a wider scope, clearer pictures, what is it?
It's a much larger transducer. It's got all the newest technology, so it's as good as your best handheld ultrasound machine. But the main thing is that it's automated, so it's less time that the radiologist needs to actually be scanning the patient.
So normally it would take how long?
Depending on the size of the woman's breast, it can take up to a half hour per breast, actually.
And this?
And Cheryl?
Maybe maximum 15 minutes
So 15 minutes.
for both.
For
Sure.
both.
Now, so is it common that they do mammography, a mammogram, and this in the same day, or is this separate?
Yes, usually in the same day. Or if the woman's had a screener, then I notice her dense breast, then we call her back. And right now, because it's in the study phase, even though it's been FDA approved, we're doing these free of charge. And for a woman, and they don't even have to have gone to our center, Randy, but for a woman to qualify for free automated breast ultrasound, they just have to have had a mammogram in the last month and have optically dense breasts.
What about those that say mammography is old technology, it's all ultrasound now? Not the case?
No.
Okay.
You need both. You really
both.
do need both. But they just work so well together in a person with dense breasts. If somebody has fatty replaced breasts, this is not necessary. It's only when they're dense breasts or patches of density. And let me take you on to the next
Sure.
modality. Once the mammogram is completed, the technologist will develop the mammogram. The films will fall out through here, the processor. The technologist will hang them up on the board and examine the films, make sure that there's no artifact. And then we'll do what's called CAD, or computer-aided detection.
Now this looks at what you've already looked at. Is that correct? To see if you missed anything?
Correct. Correct. It's
Okay.
taking our film screen, digitizing them, the computer's analyzing them, and then the digital images come up at my viewing station with marks put on by the computer telling me where it thinks there might be a possible lesion.
Is this common? I mean, is this used?
This is actually now standard of care in the desert.
Okay, good, good.
Yeah, it's very good. It's like having a second radiologist staring at the films over your shoulder, keeping you honest.
Okay. So now so the process continues. Now you've put it through CAD, now what?
And now we would come over to the viewing station, or my bat cave, because it's always so dim.
A little
And
dim in here.
show you kind of bring all of our technologies
So this is
together,
where
Randy.
you read the mammography
This
and the
is
ultrasounds and everything.
Correct. This is where it all happens.
So now you found something. So how do you diagnose it as a cancer?
It needs to be biopsied, and almost all lesions that you're suspicious of now can be needle biopsied. So I'd like to take you into one of our rooms and show you a certain type of needle biopsy called
this
a
is the biopsy
stereotactic
room?
needle biopsy.
Okay.
This is our stereotactic room, and this is the room where we do a particular type of needle biopsy that incorporates mammogram unit and a computer, and it uses digital technology. The woman lies on the table. It actually starts out at near ground level. She lies down, her breast goes through a hole in the top of the table, red balloon again symbolizing the breast, and it's compressed below by a little mammogram unit. And the tech positions the breast where the lesion is, takes some photographs that show up where Cheryl is by the monitor, and lets us know whether we have the area that needs to be targeted in basically our playing field. And then it uses the Cartesian system of geometry to figure out where this is in three-dimensional space.
Is this a painful procedure? Not very painful?
It's not very painful. As a matter of fact, the only complaints in the last 10 years that I've gotten from patients are that their neck gets stiff from lying on the table. It's not their breast. And it's done with local anesthetic.
Went to other places, and they told me I was fine and to come back another year. Had I not taken Dr. Lander's advice, I don't think I would be here. On the advice of Dr. Lander, sure enough, we found out that I was positive for cancer, so I had a lumpectomy. But then I wanted Dr. Lander to follow me, because to me it's very important who is going to give me the x-rays, and she's an excellent radiologist, very conscientious. She does sonogram and everything, very conscientious. Knowing that I had breast cancer, she followed me every 3 months. Did an ultrasound, was not sure, but wanted to see me every 2 months. The next 2 months, I was positive for cancer again. The other breast, and this time different cancer. She knew it was aggressive cancer, and I didn't think twice. She made all the arrangement, and 10 days later, I had a bilateral mastectomy. If it wasn't for the second time, she had saved my life. So, I'm not going anywhere. I'm just staying with Marla and I tell all my friends that.
Now, we've had you on the show before. Now, since that time, and I'm sure there still are women out there that are being told all the time, get your checkup, get your mammogram, and they're not doing it. I mean, that's still the case?
That's still the case. That's still the case. In Coachella Valley in particular, I don't know what the statistics are for women that are eligible that aren't coming for mammograms, but in California it's almost 40%.
Nationwide?
Not coming.
Nationwide is 40%?
No, California.
How many women a year are being diagnosed with breast cancer?
Last year, the American Cancer Society said that there's been over 216,000 in the U.S. diagnosed, and their projection for next year is 250,000.
So what's your take? Why do you think women aren't coming in for their annual mammogram?
I think that part of the problem is fear. What if we are going to find a cancer? And to those ladies, I'd say for every 1,000 ladies that come in, 995 will not be diagnosed with cancer. It's tremendous odds. So don't not do it because you're afraid of the results. Another thing, they're afraid of pain because a friend of theirs told them how much it hurt. So to those women I say, you know what, with modern technology and good dedicated technologists, it shouldn't be an issue of pain. If you're menstruating, don't come during your period. The optimal time to come for your mammogram is really day 7 to day 14 of your cycle. If you're not menstruating, it's not even an issue.
Now, I asked you off camera, and I said, if somebody goes to see you every year, over 40, and they get their mammogram, chances are they're not going to die of breast cancer.
That's correct. Chances are. It doesn't mean that it won't happen maybe once or twice in the whole practice, but most breast cancers are not born big, and by that I mean they're not born so aggressive out of the chute that you can't catch them within a year. So the ones that will be missed or that might have a chance to become more aggressive are the ladies that are not coming every year.
What about a woman that says, you know, I'm lean, I'm fit, self-exam is all I need? What is your response? Totally
incorrect.
Because why is that incorrect?
Especially in the younger age group, 40 to 49, a mammogram's going to catch even an aggressive tumor 2 years before she'll ever be able to feel it, even if she's very thin with minimal breast tissue. That's why mammography is so important. Give us that time to treat it when it's early, when it hasn't reached such an aggressive stage where it's already metastasized.
So by the time it's a lump that you could feel, what happens?
Well, over the evolution of the tumor's growth, it might start out as grade 1, meaning least aggressive, and then given enough time, and especially in a young woman with all the hormones pouring through her system, that tumor can actually grow not only in size, but in how aggressive it is. So by waiting a longer amount of time, you're allowing that tumor to become more aggressive and gain its potential to metastasize throughout the body.
Let's move on to ultrasound. Now, the ultrasound you have, according to my notes, 10 in the United States.
You're referring to our automated breast ultrasound system.
Okay.
Yes, there's only 2 manufacturers in the United States. This is an FDA-approved process or modality, but the purpose of it is to try and introduce screening ultrasound to women, not just use ultrasound as a diagnostic tool, meaning once there's an abnormality found in the mammogram or once the woman has a lump, at that point you do ultrasound. Here, you just take a woman with an optically dense breast, the machine's automated, you hold this large paddle over their breast and it scans the whole breast, digitizes the information, and then sends it to the radiologist next to our view station. So I can be looking at the woman's mammogram and then see her U-Systems ultrasound right next to it. So it's just great information. Everything's right there when you need it, and you can make a diagnosis.
MRI for breast cancer. Tell me about that.
MRI is very important for breast cancer, but not to the exclusion of the mammogram or the ultrasound. MRI is an adjunctive tool, just like ultrasound is an adjunctive tool to mammography. It gives us different additional information.
So the thermography. Some people think that it may replace mammography. What are your thoughts?
It's a nice thought, Randy. It's totally untrue. And I don't know if you know the history on thermography, but it was actually around before they were doing mammograms. There was thermography, then zero mammography, which was basically like taking a Xerox or a copy of the breast. Then we developed film screen mammography. Thermography was horrible at detecting breast cancer.
What about now?
It's not better now. The only thing now is that they coupled it with tomography so that you can do images through the breast. So it looks really cool on computer, but, and you can quote me on this, it's virtually worthless.
What about peace of mind? I mean, we've talked a lot about the negative, but what about the positive?
You know, for those women who might have a family history and are avoiding a mammogram because of what it might show them, they're living their day-to-day lives wondering if they might even have a breast cancer at that point in time, and they just don't want to deal with it.
I know women that have premonitions. They say, I've always worried about breast cancer. They're 45. I said, well, do you get your annual checkups? No, I don't want to know. But
it's the craziest thing to me, but think of all the women that are pouring in and out of here all day long, Randy. Like we said, 995 out of 1,000 are leaving here with peace of mind.
So they're walking out all day happy.
Yeah, and
thrilled.
After that, they can totally put it behind them.
But then they're
go
sold,
on with their
it
lives
sounds
for a
like.
year. Yeah.
I mean, once they get one and they're clean, they come in every year.
Exactly, and they find out it doesn't hurt and it wasn't that terrible a procedure like what they've heard. Correct, then it's no big deal for them to come back every year.
Now, what else are you doing here? I mean, anything that is not common in a breast center?
One of the more unique things we're doing here, Randy, is cryoablation, which is actually freezing a tumor, causing death of the tumor, and then the body reabsorbs it. It's instead of having to have surgery.
So who is a candidate for this?
Right now, according to the FDA guidelines, somebody who's been diagnosed with a benign tumor through some kind of needle biopsy, instead of having to go to surgery to have your benign tumor removed, such as a fibroadenoma, which is a very common tumor, especially in young women, that's hormone sensitive. So the longer that they're going through their menstrual cycles, and especially with pregnancy, this tumor continues to grow. So that's why even though it's benign, it'll usually be surgically removed, so it just doesn't get to the point where it's so huge that the lady eventually has to go in and have a huge scar.
So how do you normally get rid of them? And how does cryoablation fit in?
Normally they're removed surgically, especially in somebody who has not had children yet or is still planning to have children, because these things grow like wildfire when a person's pregnant.
So what do? You freeze it? You put a probe? What is it?
It's really cool what we do. I like this technology.
Okay.
You anesthetize the skin. Then you put this very slim probe in that's about the size of a biopsy needle into the center of the tumor, if you will. This is the tumor. The probe's going right through the center. And then you turn on the system. It uses argon and helium gases. And you freeze the probe, which then in turn freezes the surrounding tissue. We're talking about temperatures down to minus 187 Celsius, which I think is about 305 degrees Fahrenheit below zero.
Okay.
Amazingly cold temperatures. And this ice ball grows within a minute or 2 minutes. It's fantastic. So we watched it under ultrasound guidance, and you can actually see the ice forming.
So then is it sucked out?
It's not sucked out. What happens is that you go through a freeze-thaw, freeze cycle. The largest tumor we can get right now is 4 centimeters, which is a fairly good sized tumor. Sure. A 4-centimeter tumor will take us 20 minutes. If they're smaller, you know, there's a whole algorithm that you plan out beforehand based on the tumor size. So a smaller tumor might take as little as 6 minutes to freeze. Then when the procedure is done, you hit the helium portion, which actually thaws out the probe, and you're able to pull the probe back out. The ice ball remains in the breast. And the funny thing is the woman's feeling nothing during this whole procedure. And afterwards, when we're holding pressure over the site for a few minutes, you take their hand and you put it over this tumor, and they just freak out because it really feels like it's a hard ice cube in their breast. And then that dissolves and softens up over the next half hour. But essentially, you've killed almost all of the tumor cells right then and there.
Cryoablation.
Cryoablation.
You're the only one doing it in the desert?
Oh, and by the way, let me jump back a minute. What happens to the tumor, because you might think, well, am I just walking around with this dead, huge, soggy tumor in my breast afterwards? And it's not the case. Your immune system actually will reabsorb it over time, usually up to a year.
Now, you're the only one doing it in the desert?
Correct.
Okay,
and
so
I'm one of the only radiologists around the country doing them right now.
So if they don't go to you, they have to be cut out?
Or they can go to a surgeon who's, I don't know if we have any surgeons in California doing them. I know
now,
they're
who'd
in
opt
Washington.
to do that? Just somebody that doesn't know their options, obviously, right?
Correct. And it's, you know, it's such a brand new technology that word hasn't gotten around yet.
Dr. Lander, I want to thank you for coming on the show. And thanks for allowing our cameras here. And the tour, great place, beautiful artwork, and always a pleasure.
Thank you very much, Randy. It's been a pleasure for us, too.
You've been watching The Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. If you would like to view this interview in its entirety, you can visit our website at wellnesshour.com. For now, I wish you good health.
Thanks for watching The Wellness Hour, the leader in medical news with your host, Randy Alvarez, the authority on health issues.